that we need to talk about some anatomy. I'm sure Gargi ne padhaya hoga, but just a refresher course. So first you need to know about coronoid notch. Coronoid notch, what is it? It is the deepest portion of the anterior border of the ramus, which is this part, okay? Then you need to know about pterygomandibular raphe, okay? It looks like a thin mucosal band in the intraoral cavity, in the mouth. So what is a raphe, pterygomandibular raphe? It is not a ligament, it is just the junction of two muscles, okay? I'll show you a video. Yeah, so can you see this? This is the buccinator muscle. Then we have a superior constrictor muscle that is present in the walls of the pharynx, okay? So the point, the junction where these two muscles unite, okay, that is called as pterygomandibular raphe. And then you can see just lateral to this superior constrictor muscle, we have the medial pterygoid muscle. Let's see. Okay, so this is the buccinator muscle, superior constrictor muscle, and this is the pterygomandibular raphe. Okay? So this is the pterygomandibular raphe, and we have this medial pterygoid muscle. Rotate kar. Okay, so you can see lateral to the superior constrictor, we have the medial pterygoid muscle, which is pretty close to the pterygomandibular raphe. Okay? And we are going to insert the needle at this site. Okay, so it is pretty close to the medial pterygoid muscle. Okay, this is going to come into play later on in the complication section at least. Okay, then I hope you remember there is parotid gland at the posterior border of the ramus. So this is the parotid gland. If we view it from the superior aspect, you can see it engulfs the posterior border of the ramus. Okay, so when we give inferior alveolar nerve block, our needle might go into the parotid gland and we might accidentally deposit the local anesthesia solution in the parotid gland. And parotid gland may we have the facial nerve, and that will lead to facial nerve palsy, which will be temporary of course, but that is a complication. So another thing, just a first quick refresher about the nerve branches. This is the inferior alveolar nerve, which is going into the mandibular foramen. We have the lingual nerve, and this is the buccal nerve, which crosses the anterior border of the ramus and supplies the buccal periosteum and the mucosa. Okay, and if you see this inferior alveolar nerve, jahan pe bhi nerve rahegi, it is going to supply that area. So it is going into the ramus through the mandibular foramen. So it is going to supply the inferior portion, inferior half of the ramus, and it is inside the mandible. So it is going to supply the body of the mandible and the teeth. Okay, and the surrounding tissue. So mental foramen ke bahar we see the mental nerve that is coming out. It is going to supply the labial mucoperiosteum anterior to the mental foramen and the lip region. Okay, and at the mental foramen, at the point where the mental foramen is present, our inferior alveolar nerve, it divides into two branches. Okay, the one that comes out of the mental foramen is the mental nerve, and the one that continues inside is the incisive nerve. Now, you remember that this nerve, inferior alveolar nerve, it continues in the mandible, inside the mandibular canal. Okay, so now this canal continues as a single canal. Okay, but beyond this point, beyond the mental foramen, it is called as incisive canal. It is one single structure, but beyond the mental foramen, it is called as incisive canal, and before the mental foramen, it is mandibular canal. Okay, so this is just the same thing. If you see, you have the mental nerve coming out of the mental foramen. You have the inferior alveolar nerve going inside the mandibular foramen. And now you are going to see the incisive nerve that is supplying the anterior teeth, premolar to central incisors. Okay? So, before any injection, you need to know something about basic injection techniques. मैं इसमें डिटेल में नहीं जाऊंगा, ये टेक्स्ट बुक में लिस्ट दी हुई है. But according to me, the most important steps in this are these two: communicate with the patient and communicate with the patient. Talk to the patient. So if you talk to the patient, majority of the pain, the anxiousness, it is elevated, like it is removed as the patient becomes comfortable with you. Okay, apprehension कम करना है patient का. So now we come to the actual topic, that is techniques of mandibular anesthesia. We have different techniques, but तुम्हें मैं basically जो textbook में दिया है, the one that you are more concerned with, we're going to talk about that more. I'll give running commentary, like passing comments दे दूंगा थोड़े, which are not given in the textbook, but we sometimes use them. Anyways, so we have mandibular anesthesia. Intraoral techniques, they are subdivided into two categories: open mouth technique and closed mouth techniques. Closed mouth technique में एक ही है Vazirani echinosis, in which the patient is not able to open the mouth. Okay, in that condition we can give that. And in case of trismus, suppose for some reason we are not able to give Vazirani echinosis also, there is something called as extraoral technique also, in which we insert the needle extraorally through the sigmoid notch यहाँ से, okay, and we block the mandibular branch, main trunk of the mandible nerve. Okay. Another technique is we insert the needle from here. So the basic target is that we need to anesthetize the nerve. We know the position of the nerve. It is medial to the ramus. अब कहीं से भी insert करो needle, we just need to anesthetize that part of the nerve. Okay. So closed mouth technique में we have only one, that is Vazirani echinosis. And open mouth technique we have many. Inferior alveolar nerve block, the name is Halsted technique. Lingual nerve block, buccal, go gates, mental, incisive. So I'm going to go in detail in this inferior alveolar nerve block, because this is the most common that you are going to use. Okay, बाकी सारे I'll talk, but उतना detail में नहीं जाऊँगा मैं. Okay, चलो. Now we come to the inferior alveolar nerve block. Now, what are the nerves anesthetized? So you remember, कहाँ गया? Okay, so this is the inferior alveolar nerve. It goes in. We anesthetize this nerve at this point, right? Right before it enters the mandibular foramen. उसके आगे कौन सी branches हैं? We have the inferior alveolar nerve and its branches, that is the incisive and mental nerve. So the nerve anesthetized are inferior alveolar, incisive, mental. And now we have the lingual nerve, which is pretty close to the inferior alveolar nerve. Okay. So most of the time when you give an inferior alveolar nerve block, the LA solution, it flows, it diffuses to the lingual nerve also. Okay. So in majority of the cases you will see lingual nerve block also. The nerve lingual is anesthetized, but not always. That is why we always give lingual also. Okay. Now, areas anesthetized. मैंने जैसे बताया था last time, inferior border, inferior portion, inferior half of the ramus is supplied by the inferior alveolar nerve. So this is anesthetized. Body of the mandible is anesthetized. Teeth are anesthetized, and we have the buccal periosteum, mucoperiosteum, from the mental foramen to the midline, because this molar region is supplied by the buccal nerve. Okay. And as I mentioned earlier, majority of the cases lingual nerve is blocked. Okay, so we're going to see the lingual mucoperiosteum that is blocked, and we have the floor of the mouth, tip of the tongue, anterior two-thirds of the tongue, that will be anesthetized. Okay, so these are the areas anesthetized. Now indication. So we have a large area that is being covered by one single block. So any procedure that involves multiple teeth, that is the indication. Any soft tissue surgery anterior to the mental foramen, that is the indication. Okay, multiple teeth, buccal soft tissue anterior to mental foramen, lingual soft tissue anesthesia, that is, as I mentioned, it is not always there. So this is a very questionable indication. Book में दिया इसलिए मैंने डाला हुआ है. Okay, so contraindication, just इसमें जो contraindication बताऊंगा, it is given in every block. उसमें ये contraindication रहेगा. Like if you remember neurophysiology परसों का pH, if the site, the tissue pH where we deposit the local anesthesia, if it is acidic, less than 7, okay, the efficacy of the local anesthesia is reduced. Okay, so that is one, infection or inflammation. Then if the patient in any block where the lip is anesthetized, okay, any patient where the patient is not capable enough to take care of his lip, anesthetized lip, उस पर bite कर लेगा. So a child patient or a mentally challenged patient, okay, in such patients we avoid such blocks. Okay, we try to do it with the infiltration. Okay, so alternatives, मैं इसमें ही alternative बताऊंगा. I'll show you how to think about the alternatives. बाकी किसी block में नहीं दिखाऊंगा. So you have a procedure where you want to, for some reason, patient का accident हो गया. If the patient has a laceration in the lip region, you want to suture it. So just for the lip, you don't have to give a inferior alveolar nerve block. You can just give the mental nerve block. Okay, to anesthetize the lip. So depending on the condition, you can give a block. So another, if you want to operate on teeth like premolar to central incisors, okay, in any of these teeth, you don't have to give an inferior alveolar nerve block. You can go for incisive nerve block. The incentive for going for incisive nerve block in this case is it has lesser complications. Now inferior alveolar nerve block, we have complications like hematoma, trismus, facial nerve paralysis, right? Whereas incisive में there is only one documented complication, that is hematoma, which is also very rare. Okay, and the site of injection is easily palpable. So the success rate is almost 100% in incisive. Okay, so you have a better chance of achieving proper anesthesia with incisive as compared to inferior alveolar nerve block. Okay, then if you have a single tooth RCT कर रहे हो, then you can go for PDL injection. Then for some reason you're not able to deposit LA in the pterygomandibular space, the space where we are going to block the inferior alveolar nerve. वहाँ पे suppose there is a space infection, so we can go for go gauge technique or the extraoral technique. Okay, then we have, for some reason patient has a trismus. If the patient has trismus, as I mentioned earlier, we have 3 techniques available. Intraoral mein we have only one, that is Vazirani echinosi. Extraoral mein we have this technique where we insert the needle through the sigmoid notch, or one is Thomas technique, which we insert the needle at the inferior border of the mandible. Okay, medial to the inferior border of the mandible. Okay, now I hope you guys know what a bevel is. Needle का आगे का जो cut portion होता है. Okay, so I'll just go through what is the importance of bevel. So this is the bevel. What's going on? Okay, this is the bevel. So majority of the time when you are approaching the bone at an angulation, you have to make sure that the bevel is towards the bone. Okay, let's see. So in this case, we are approaching the bone. So this portion is the bone. This red portion is the periosteum. Now periosteum is, first of all, it has a rich blood supply. Second, it has a high sensory supply. Okay, so थोड़ा सा भी injury होगा, the patient will have more pain. Okay, comparatively. So when you approach the bone at an angulation, so because the bevel is towards the bone, it is going to slide. Okay, it won't tear the periosteum. That is one thing. दूसरी चीज़ मैं बाद में बताऊंगा. Then if we approach the periosteum we keep the bevel away from the bone. So directly tip is going to engage the periosteum. Okay, and it will tear it. That is one thing. Second, it might get bent. Okay, it gets bent. Now it has already, when we inserted the needle, we tore the periosteum, patient को तब pain हुआ, and the needle got bent. Okay, it is called as a barb. Now when you withdraw it, it is going to engage the soft tissue while coming out. It is going to tear the soft tissue. Because of that also, patient will have pain while withdrawal. Okay, so if we keep the bevel away from the bone, patient will have pain at 2 instances, when we contact the bone and while we withdraw. And if we approach the bone at a 90-degree angle, it doesn't matter क्या direction रहेगा bevel का. Okay, but you have to make sure that you contact the bone gently, pressure नहीं लगाना है. Okay, so this was the orientation of bevel. Now we come to the technique. Now landmarks. In any blocks, if you have read properly the Malamet textbook, local anesthesia textbook, in that we are given a set of landmarks in every block. So basically landmark का काम क्या, they act as a reference point. Even in a general sense, किसी city में भी आप कोई landmark बोल रहे हैं, we use those landmarks as a reference point to reach the final destination where we want to go, right? So in this case of blocks also, we are going to use these landmarks as the reference point to make sure that our needle tip is at the point where we want it to be. Okay. So when we talk about a landmark, we need to know why we are reading about it, how to use it as a reference point. Okay, so the first landmark is coronoid notch for the inferior alveolar nerve block. So coronoid notch, as I mentioned earlier, deepest portion of the anterior border of the ramus. So what we are going to do is, पहले दूसरा बता देता हूँ, pterygomandibular raphe. So what we do is let me see, occlusal plane, जाने दो इसको, bevel. I hope you guys know all the positions, वो सब मैं नहीं जाऊँगा, and supine semi. Okay, so what we do is, how we use the coronoid notch, we place the thumb at the coronoid notch. It is the deepest portion of the anterior border of the ramus, and we draw the line between the deepest portion of the raphe and the coronoid notch. Okay, and we divide it into 4 portions, just imaginary, draw करते नहीं बैठना है. Okay, of course. So either 1/4 distance from the raphe or 3/4 distance from the coronoid notch. That is the point where we are going to insert the needle. वहाँ पे needle insert करेंगे, and this point is 6 to 10 not centimeter, it is mm. Centimeter बहुत ज़्यादा हो जाएगा, skull में चला जाएगा. This is a typo. So 6 to 10 mm above the occlusal plane. So this is how we use the 3 landmarks: coronoid notch, pterygomandibular raphe, and the occlusal plane. Okay. So this is where you insert the needle, and if you keep the barrel of the syringe, जिसमें LA load करते हैं, if we keep the barrel of the syringe at the premolar region, corner of the mouth, and if we insert the needle and we advance it, chances are if you followed everything properly, then you are going to contact the bone, and that site will be just near the mandibular foramen. Okay, so just when you hit the bone, just withdraw 1 mm and deposit the LA 1.5 ml over a period of 60 seconds. I will tell you the importance why we have to deposit the LA at such a slow rate. Ideal rate is 1 ml per 60 seconds. You can do 2 ml per 60 seconds. वो next to next lecture में आएगा, but you'll understand. So this is the site. If we follow the technique, you're going to advance the syringe from the premolar region, and you're going to reach the mandibular foramen. Okay, so this is the injection site, and this is the inferior alveolar nerve. We are blocking it before it enters the mandibular foramen. Okay, so yeah, coming to the lingual nerve. इसमें दिख तो नहीं रहा है, but if you remember the diagram, lingual nerve is somewhere here, slightly medially. Okay, it is placed slightly more lingually and anteriorly. So what you can do is, now tell me, आप लोगों को कौन-कौन ये follow करता है that you withdraw the syringe, take it to the same side and then deposit the LA for the lingual nerve block? अच्छे से ऊपर करो यार, खाना तो खाया ही होगा. Okay, हाथ नीचे कर, तू भी करता है अभी भी. Okay, so it is not required. If you do it, that is fine. It is not contraindicated, but it is not required. Okay, as I mentioned earlier, it is the lingual nerve is placed anteriorly and more lingually as compared to the inferior alveolar nerve. So if we withdraw in the same direction, you will be close to the lingual nerve. So you don't have to do that, taking the syringe barrel to the same side. You can just withdraw it half the length and deposit the LA, and you will be able to block the lingual nerve. Okay, so that was your lingual nerve block. समझ आया इतना अभी तक? I hope, yeah. Yeah, so withdraw half the length and deposit the LA. Now, this is what I do in my private practice. अभी तो बंद कर दिया. But what I do usually, I give block to the patient, and I ask the patient to sit outside. Okay, and in that time, during that time, I prepare for the surgery. It takes around 5 to 10 minutes to completely prepare for the surgery. उतने time में patient का LA भी अच्छे से block हो जाता है. Even if you have not deposited the LA immediately at the mandibular foramen, even if you have deposited the LA inside the pterygomandibular space, okay, given enough time, it is going to flow throughout the pterygomandibular space, and it will reach, the LA solution will reach the foramen. Okay, if you give more time. Okay, so what are the signs and symptoms? As I mentioned earlier, if you know the anatomy and the area supplied by the nerve, you will be able to easily figure out what are the signs and symptoms. Okay, so subjectives are the symptoms that are experienced by the patient. Okay, whereas objective that you see, that you check clinically. So subjective में patient को lip anesthesia रहेगा. Okay, in majority of the cases, you will see the tongue anesthesia, tip of the tongue पे patient will feel numbness. That is the subjective. In objective, there won't be any pain on instrumentation. That's it. Instrument से थोड़ा सा poke करके देखो, there won't be any pain. That means the LA has acted fine. Okay. And precaution. As I mentioned earlier, ज़्यादा force से needle insert नहीं करना. That will lead to more pain. And do not deposit the LA if you have not contacted the bone, because you might go into the parotid gland. That is where you might accidentally deposit the LA and lead to transient facial nerve paralysis. It is transient. 1-2 घंटे में खुद ही ठीक हो जाता है, but patient डर जाएगा. And if you are not experienced, आप भी डर जाओगे. Okay. So now we come to the point where even after proper technique, there is a possibility that you might hit the bone early, or you might not hit the bone at all, even after following proper technique. Okay, so there are many variables in the inferior alveolar nerve block. Okay, first is patient variable. That is, if you know, you can see the body of the mandible and the ramus, it is at an angulation. Now this angulation varies in every patient. यहाँ पे it is an average angulation that is given, but in every patient it is different. In some patient the angulation will be higher, leading to even after a proper technique, this angulation is higher. You might not be able to contact the bone, or the angulation is less. So even after a proper technique, you might hit the bone early. Okay, that is one. Second problem हो सकती है that you don't insert the needle at the 1/4 distance from the pterygomandibular raphe. You insert the needle too laterally, then you will hit the bone early. Or if you insert the needle too close to the pterygomandibular raphe or lingual to the medial to the pterygomandibular raphe, then also it will go like this. It won't hit the bone. Okay. Another thing, एक और चीज, if we insert the needle here, but the barrel is too posteriorly, okay. Of course, molar, first molar या second molar के पीछे तो जा नहीं सकता. There is a lip, okay. So if the angulation is like this, you will hit the bone early. If the barrel is in the incisor region or canine region, the angulation will be like this. So it will go and it won't hit the bone, okay. So these are many variables. But एक बार आपने needle insert कर दी, you should not take it out completely. You're going to introduce the patient to more pain if you insert the needle again. So there are tricks available that you can use to achieve proper bone contact and then deposit the LA. Even after performing these mistakes, या फिर the patient has a angulation, anatomic variation. So in this case, we have early bone contact, okay. So what we can do, we draw the needle till the tip and then move the barrel towards the midline and then advance the needle, and you will be able to contact the bone properly and deposit the LA. Next is, we have inserted the needle. यहाँ पे I have intentionally kept it at the incisor region. So when we advance the needle, we are not going to contact the bone. There is no bone contact. So we are going to pull it out till the tip and move the barrel more away from the midline, and then we hit the bone. Okay? Understood? So this is your this is what you do when you don't contact bone or if you contact the bone too early. Okay. So what are the reasons to achieve anesthesia? Failure to achieve anesthesia. Do you know something called as bifid mandibular canal? सुना होगा. So उसमें बाद में if you don't deposit the LA, this is logical. If you don't deposit the LA at the proper site, you won't be able to achieve the anesthesia. But जैसा मैंने बताया, if you give it enough time, it will flow to the site and it will lead to some anesthesia. Okay. Then again, too anteriorly, too inferiorly, वो जाने दो. Accessory innervation, this is important. Now, especially in the mandibular, molar and premolar region, lingually we have the mylohyoid nerve, okay, that is pretty close to the lingual cortex, okay. In some cases, the sensory fiber, usually the mylohyoid nerve is totally motor, okay, but in some rare cases it also carries some sensory fibers which are then supplied to the molars and premolars, okay. So even after a successful nerve block, okay, successful inferior alveolar nerve block, the patient might still have pain on lingual instrumentation, okay. Lingual पे आप instrument लगा रहे हो and the patient might still have pain because the chances are the patient might have accessory innervation from the mylohyoid nerve. So what you can do for that is, जिस भी tooth में pain हो रहा है वहाँ पे आप बस lingually you infiltrate the area. That's it. Those fibers will be blocked and the patient will have no pain. That is the first thing. Second, on the buccal side, in the molar region again, we have the spinal accessory nerve. Oh, I forgot to show you this. So this is the mylohyoid nerve. It can supply the molar and premolar regions. Then we have cervical accessory nerve. That supplies the buccal aspect of the molars in rare cases. Okay. So even in those cases, if you experience pain even after proper block, long buccal and inferior alveolar nerve block, if the patient still have pain, then you'll have to infiltrate the area, immediately buccal to the tooth. Then we have the bifid and inferior alveolar nerve. There are many, almost 6 to 7 variations of bifid nerve. वो सब जानने की ज़रूरत नहीं है. You just need to understand two things. One, the nerve enters the foramen and then it divides into two, or it divides into two and then enters the foramen. So basically in first scenario there is only one foramen and then we have two nerves. Okay. In this case there is no issue because यहाँ पे एक foramen को हमने block कर दिया. We block the nerve before it enters, before it divides into two. So it doesn't cause any issue. The problem is here when it divides into two and then enters the mandible. Okay. So there are basically two mandibular foramen. So okay, so we block one, but second is still, it is not anesthetized. So the patient will have pain because both of these are going to supply the teeth. Okay, so how do you detect this? This is only detected by the radiographs, OPG. Okay. So in this case, this is the OPG of the patient. You can see there are two mandibular canals. easy to visualize. You can see two mandibular canals. One is at an inferior position than the normal. Okay. So if you suspect that there is a mandibular, there is a bifid mandibular canal, there is a bifid nerve. So what you can do is, you know that the other one is at a lower level. So what you can do, you can insert the needle at an inferior level. अभी तक हम क्या करें, 6 to 10 mm above the occlusal plane. You can go 5 mm below that, insert the needle, and you'll be able to reach the second foramen and deposit the LA there. You'll be able to achieve anesthesia in both these. Okay. So these are the reasons. First is technique आपकी गलत है, उसका तो कुछ नहीं कर सकते, ठीक करो. Second, accessory innervation and bifid nerve. Then there is another thing. Suppose you have given the block properly, but when you try to perform any procedure in the anterior region, especially central, lateral, and in rare cases canine, patient can still have pain after successful nerve block. Okay. Even if you infiltrate the buccal lingual, still there is a possibility. In the molar region का बता रहा हूँ, but anterior में there is a possibility, there is pain. क्यों? There is something called as cross innervation. Now anatomy, as I mentioned earlier, it is not absolute. There will be variations. So at the midline, we have the nerve supply coming from both the sides. Okay. So it's not that कि बीच में ये area तेरा ये, sorry, अब मेरी turn. Okay. So at the midline, we have the nerve supply coming from both the sides. अब ये गैंग वॉर तो है नहीं, ये एरिया तेरा ये एरिया मेरा है. They both cross the midline and supply the teeth to the opposite side also. Okay. So central and lateral, and in rare cases canine also. In some cases they might have the blood supply from the opposite side, nerve supply from the opposite side. So the teeth at the anterior portion of the mandible, they might have nerve supply from two sides, from the same side and then the opposite side also. So suppose even after a successful block, if the patient has pain in the anterior region, anterior teeth, then you will have to infiltrate the midline. Midline पे आप infiltrate करोगे, all of the innervation coming from the opposite side, it will be blocked. Okay. So that is how you manage the cross innervation. समझ आया इतना? किसको नींद आ रही है? Okay. Now we come to the complication. As I showed you in the video earlier, just lateral to the superior constrictor muscle, we have the medial pterygoid muscle. Okay. So again, the anatomy is not absolute. There will be some variation. Sometimes the muscle, medial pterygoid muscle, is more close to the pterygomandibular raphe. So when we insert the needle multiple times, the chances are that you injure the muscle, medial pterygoid muscle mein you are inserting the needle multiple times. Okay. So because of the multiple trauma, the muscle might go into spasm. It is like after a heavy workout, आपका नेक्स्ट डे हाथ भी सीधा नहीं हो पाता है बिकॉज ऑफ मसल स्पाज्म. वंस यू गो टू स्लीप, ओके, सेम डे पे इफ यू परफॉर्म इफ यू परफॉर्म द मल्टीपल पंक्चर्स ऑफ द मसल, ओके, सेम डे पे नहीं होगा. वंस द पेशेंट स्लीप्स, अगले दिन उठेगा, मुंह नहीं खुलेगा उसका. ओके, सो दैट इज ट्रिस्मस. अनदर थिंग, LA, the LA that you deposit, it is myotoxic. Okay, myotoxic means it causes irritation and necrosis of the muscle fibers. Okay, so it is also a reason that if you deposit LA too close to the muscle or inside the muscle, that will lead to damage to the muscle fibers, and even that will lead to trismus. Okay, then we have hematoma. Hematoma होगा तो इसमें हम कुछ नहीं करेंगे. Actually, we'll just let it form. It will grow in size and then it will stop. So basically, we just have to make sure that the patient is comfortable. That's it. Then, one second. Hello. Lecture ले रहा हूँ. Bye. My junior. Okay, facial palsy. मैंने बताया हुआ है. क्या हुआ? Facial palsy. So we have the parotid gland at the posterior border of the ramus. So if you don't contact the bone and we just go in, all of the needle is inserted in the soft tissue and you deposit the LA without contacting the bone. So you will deposit the LA in the parotid capsule, and that's where the facial nerve is. So you're going to cause transient facial nerve paralysis. Patient का facial expressions एक side के बिल्कुल नहीं होंगे. Okay, but the good thing is that it is transient. जब तक LA का इफेक्ट रहेगा, the facial nerve paralysis will be till then only, and then the patient will recover. Okay, so even in this case आपको कुछ नहीं करना है. Just tell the patient it is not that uncommon. It happens in some patients. You don't have to worry about anything. एक दो घंटे में ठीक हो जाएगा. जस्ट मेक श्योर इफ द पेशेंट वेयर्स लेंसेज, उसको लेंसेज निकालना है, एंड यूज आई ड्रॉप्स बिकॉज पेशेंट विल नॉट बी एबल टू क्लोज हिज आईज. ओके, सो मेक श्योर द पेशेंट यूजेस आई ड्रॉप्स lubricants. Okay.